So last time we talked about Hep B, you explained a little bit about the pathology of the disease, how it works, the chronic forms of hepatitis, the forms that are more easily treatable and solved as a one-time thing, but the ones that can lurk in your system forever. Just as a brief recap to remind listeners, perhaps who didn't have the chance to tune into that first part of the discussion, which are the chronic forms of the disease and which are the more easily treatable?
So we gave the letters, and we said there were 5 types of hepatitis, and we're really concerned about B and C because they cause chronic infections, whereas the others cause acute infections. Now, acute infections would mean that, the person gets the disease, the virus runs its course, and then leaves the environment of the liver. Whereas the chronic, the person gets the disease and then the virus stays. Right. Now, for A, E, A, D, and E, they would be mainly from food and things like that. And this would be, just acute infections, and then they sort of get out of the body. And a lot of this is a virus. So really, we can't treat it, right, especially in the acute situation. So it will run its course like a simple cold, abdominal pain. The most feared, that shows that it's really doing something in the liver is when you get a jaundice, the eyes become yellow, things like that. But the thing about the chronic infection is that, and 6 months is a very important number for hepatitis. So the test for hepatitis is, a blood test, and then we find what we call the hepatitis antigen, which is like if a human being is wearing shirts and shorts and shoes and stuff like that, the way in which a human being has been somewhere is if you go there and there's a shirt on the floor, right?
Yeah, exactly.
Right. So these antigens are particles from the virus that are shed into the bloodstream.
So they're evidence of the virus having been there.
Exactly, right. So when we do a test for the antigen and we find that it is positive, it either means that the person has an acute infection that is going on, or a chronic infection.
But at that first stage, you can't identify whether it's acute or chronic until you've given it some time.
Well, that's why I said 6 months is an important number. Because the thing about hepatitis is that you won't really feel the evidence that anything is happening, especially in the first few weeks. It takes some time before the situation manifests. And even when it manifests, it would be like a simple malaria or, until you see some jaundice, you see extreme weakness and things like that, then you start suspecting. Now, at this point, when we do the hepatitis test and it is positive, we assume that it's an acute infection, right? So the person who is now known to have a proven chronic infection is one who either had the first test and it was positive, and then after 6 months gets a second test and it is still positive. Or a person who has no symptoms, but you do the antigen test and it is positive.
Right. No symptoms.
With no symptoms, then it means that some time ago the person had an infection, got over the acute period, but now the trousers and shorts of the virus are still there.
Right.
Okay. So, and then there's the group that is just completely negative, has never had the infection and nothing is happening. The other group that is negative is the group that has had the infection and the virus has gone its merry way and left. Right? So that person had an acute infection which did not develop into a chronic infection. Right? So that person is also negative. Now, for most hepatitis sufferers, especially for hepatitis B, most of them are in that group which will get the acute infection, and then the virus goes away, and then they remain negative, right?
That's quite reassurance, but it does have a fairly high prevalence rate according to the public health experts. So I think I'm seeing research suggesting that it's anywhere between just under 8.4% and 12.3% in the general population. And now we've heard
for Ghana and Sub-Saharan Africa.
Ghana and Sub-Saharan Africa.
So for Sub-Saharan Africa, we have that prevalence rate. It does range. Even in Ghana, it's ranging in areas between 3% and as high as 28% in different, populations, right?
And you suggested that although there might be a high prevalence rate in very concentrated urban areas for reasons of, for example, poor sanitation,
right,
and the knock-on effects of that,
right,
the ability of many people to catch a disease, it is not unknown in rural areas.
It's not. It's not. It's just that, you see, hepatitis B transmission depends on three fluids: blood, semen, and vaginal fluids.
Right. So sexual contact,
exactly,
or transfers of blood.
Transfers of blood. Now, for such transfer, you need intimate connection between human beings, right? So every situation that encourages intimate connections between human beings will lead to the transfer or the transmission of hepatitis B. So that's why I was saying that urbanization without the infrastructure that keeps people separate will increase hepatitis transmission.
Yeah.
I mean, the reason why in the developed world you would have hepatitis prevalence under 1%, and in our world you have hepatitis prevalence 10%, is just infrastructure, right? Are people more likely to share things that will allow blood to transfer from one to the other or not, right? So urbanization itself is not going to promote hepatitis transmission, but urbanization without the infrastructure will do.
It's the kind of amenities that come with the urbanization being the key thing. But you described...
I mean, for example, war is known to push transmission of hepatitis up, because war will destroy infrastructure, will put people together, right? And so it just goes back to, if we really develop our infrastructure, hepatitis transmission will come down. However, there are other things that we should talk about, and I'm sure we'll come to it, like vaccines and all that. Yes.
Well, indeed. So you also spoke about how the clubbing together without, never mind just the infrastructure, but things like few facilities. So recently, a very prominent figure in our health sector was mocked for suggesting that people eating communally or sharing drinking vessels communally was a cause of spread of hepatitis. You spoke here on the program about how, for example, sharing a toothbrush, because obviously people leave blood on toothbrushes, you open yourself to the risk of infection if you share toothbrushes. So sometimes it's just poverty, lack of access to, or culture, if you have a culture of eating together. So the National Viral Hepatitis Control Program has been set up here in Ghana, and is trying to work towards particularly a more preventative approach towards, if you like, fending off the public health risk that hepatitis poses. But what do you see as the tools that the National Viral Hep Control Program will need really to begin to have the sort of impact on our prevalence rates that you would like to see?
I'm just a clinician, so.
But you have an opinion, and it's a very informed one.
I do have a very, important opinion in this. Yeah. And I must say that whatever I'm going to say is not a prescription. No. It's just observation and what, the literature says. So we've talked about these key things. The thing about hepatitis also is the fact that if there was ever a time when a child is most exposed transmission of the virus, it's at birth. And that's what we call the horizontal transmission, right?
From mother to child.
From mother to child, right? And the key thing about horizontal transmission is the fact that once the baby is exposed at that time, then it means the growing child is exposed, and if the child becomes infected, then the child can now do the so I talked about horizontal and vertical. So vertical would be from mother to child.
Sorry.
And then after that, the child just does horizontal transmission, and that is how it spreads in the community.
Right.
So if we could cut the vertical transmission down, then, Now, vertical transmission cutting down means, first of all, knowing the hepatitis B status of the pregnant woman. Right. It means screening all pregnant women so that you know. And then it also means being ready to treat them if you find out that they have active disease, because there are antivirals that you can use to treat hepatitis B.
Because you earlier spoke of there not being any conventional treatment program, but presumably there are palliatives, and now you say there are actually antiviral
antivirals. Right. The thing was, in the acute infection, usually because the body would eliminate it in the virus, it's really is not stressed to treat.
So what are the sensible things to do if you have an acute infection? It's just healthy living, lots of fluids.
And then sometimes the associated infections that come with it, right? And then, of course, if an infectious disease doctor will need to make the decisions whether to treat the virus directly or not. So those decisions are medical decisions. But the thing is that a lot of these patients will not even end up in the hospital because it comes like a common cold and it goes like a common cold. Right. So the issues are financial. It costs money to screen the pregnant woman. It costs money to treat the positive pregnant woman. And then it also costs money because if we're saying that the most exposed the baby is going to be is at birth, then it means if there's a vaccine that you can give at birth, then you should give it so that you stop it right at the right. Ghana starts vaccination at 6 weeks for hepatitis B. Right. There's been a lot of advocacy for vaccination to be at birth. However, it's a money situation. So Ghana does 6 weeks, 10 weeks, and 14 weeks. Right. Now, according to literature, that has a significant depression of prevalence numbers. Right. However, it means we're completely neglecting the vertical, which is the most, indicative of what the prevalence levels are going to be. Right. So I would say that when it comes to vaccination for Ghana, there's still a lot of advocacy going on for us to start the vaccination at birth. At the moment, it's just 1/3 of sub-Saharan Africa which does that.
And there are no clinical reasons for not wanting to vaccinate babies at birth?
No clinical reasons. When you look at the fact that, you see, the top killer of males in our sub-region is not prostate cancer, it is liver cancer.
Oh, really?
Yes. And the thing is, you see, prostate cancer will kill, when you've crossed the 40s, 50s. It takes some time. But liver cancer is killing at 33. In sub-Saharan Africa, it's killing in the 30s. In the US, it's killing in the 60s, 70s, right? Now, there are 4.5 million children in sub-Saharan Africa who are infected with hepatitis B. and they are 70% of the world's children as far as the hepatitis burden is concerned. So sub-Saharan Africa has 70% of under 5 children with hepatitis B. Right? Now, you can imagine the implications, because there are 3 things that happen with a chronic infection. Cirrhosis, where the liver gets very fibrosed. We said that the liver was a factory. So there are a lot of rooms and blood is flowing and all that. Can you imagine some gunk filling all the rooms in a factory so that the tools that must be there just cannot find space to work? That's what cirrhosis is. It's just the liver filled with scar tissue, so nothing can go on with it, right? The thing about scar tissue staying long then is that it transforms into cancer tissue, right? So then the liver becomes cancerous, right? Yes, right. Now, the other thing is the fact that HIV and hepatitis B virus go together, because where hepatitis B virus is transferred blood, semen, vaginal fluids, it's the same thing for HIV. So where you have high levels of hepatitis B, you will also have high levels, right? Now that's what we call a co-infection, right? And co-infection means that the rate of cirrhosis and liver cancer also goes higher, right? Okay. So just coming back, so if we can sort out this, vertical transmission, we reduce the time that the child is exposed to hepatitis, right? And then we can take away the top killer of men in our environment, and it has implications on the future. We must think about the fact that we have 60 million people infected with hepatitis B virus in sub-Saharan Africa. That is the population of Ghana twice. And 4.5 million of these people are children under 5.
Under the age of 5.
Right. So, is there something we should do? Yes, it's something we should do, because these are 60 million people at the risk of having liver cancer or cirrhosis.
Extraordinary figures, or an extraordinary imbalance to have to be able to turn over in one's mind. And as you say, the potential effects of reducing the prevalence of one having a potentially beneficial knock-on effect for so many other conditions that either result from hepatitis, the chronic forms of hepatitis, or indeed conditions, diseases that occur alongside, because them being parallel means of transmission. I wondered if you knew how other countries or other parts of the world, you mentioned the small number of sub-Saharan African countries that vaccinate babies at birth, but where other parts of the world with very high prevalence rates, like I understand in Southeast Asia, there are high prevalence rates for some reason in Taiwan, and in China it's very variable, from a very low 5% to as high as 18% in China. What has been done in other parts of the world that has helped them push treatment of hepatitis as a preventative regime that has allowed them to have the better prevalence rates, particularly for children, as you said, infants, children under the age of 5?
I mean, vaccination will reduce by more than 90% the probability that a person will get hepatitis B. And that's it. It's vaccination, and having a vaccination program that takes care of the various levels of exposure and aims at the most, impactful level of exposure, right? I mean, the other things would be having, a kind of healthcare system that keeps an eye out for these, right? Now, we know that it's only 10% of hepatitis B sufferers who actually get a diagnosis, right? In sub-Saharan Africa. And it's only 10% of this 10% that get treated, right? So, I mean...
10% of 10%.
Yes. So if healthcare... So if it was 100 people, you'd get 10 people getting a diagnosis, and then you get one being treated, right? Now, if a healthcare system wants to deal with this, it just has to emphasize, first of all, on the vaccination. And then secondly, because you're emphasizing on vaccination, you will also emphasize on testing, because you will want to find out how to deal with the problem. So I can imagine that, and the data is there, that the countries that have taken vaccination seriously and testing, wholesale testing seriously, and testing with a response, right? Because if I test somebody and the person is negative, and I know that the person is going to be in an environment of high prevalence, then I should not leave the person to get infected.
You have to have the follow-through.
I have to vaccinate the person, yes, so that the person is protected against the infection. In Ghana, healthcare professionals are usually wholesale vaccinated. So I got vaccinated early in my career,
right.
And that is very progressive, and that also guarantees that most healthcare people who, especially for surgeons who are always exposed to blood, with
fluids of all kinds, yeah.
Yes. But you can imagine that in a healthcare system where that is not taken care of, then the healthcare professionals, families and all that become exposed, yes. So
you become a vector of disease,
exactly,
as well as somebody who's trying to cure the disease.
Exactly.
I wanted to ask you, because as usual, never enough time, just used to getting into the meat of something. But in relation to the vaccination program, are the vaccines universal, as in it's the same type of vaccine that would be used for an infant as would be administered to a mother who tested positive for hepatitis?
Yes. So again, the infectious disease doctors and the gastroenterologists would make the decisions. It would be based on the hepatitis B status of the mother and the hepatitis B status of the baby. Yes, but the vaccine is genetically modified and it's standard.
It works for all
It
potential
does work,
need
yes.
and users. Now that has been another fascinating view, I think, of health today. And yes, prevention being better than cure. We hope that policymakers who may have some influence, or people with some influence in this matter, are paying heed to the pressure, the lobbying that's being brought to bear. A very simple thing that can be done that could really help improve our hepatitis prevalence rates no end. Great thanks to, as always, Dr. Teddy Totimeh, a paediatric neurosurgeon, and he's very keen that we should emphasize the paediatric. He's a
Not
neurosurgeon.
really.
Well, he always insists, even if he isn't keen. But our thanks, as always, for joining us and bringing those great insights. Always learned so much listening to you on health today. Thank you for joining us again on the Asaase Breakfast Show.
Thank you very much.
And that's it, unfortunately, even though we'd like to have hung on for another half hour. Thank you for joining us this morning on the Asaase Breakfast Show. And you can join Asaase Cafe 995, which will be coming up after the news update.